They can carry their cup of tea inside. And we're going to start the next session. That is on a prosthetic valve assessment by Dr. Shrivastava. And we are going to request the chairpersons to join on the stage. Dr. Ankur Gupta, please. He is a consultant professor in PGI, Department of Cardiology. Dr. T.S. Mahant, please. Can somebody get him from the T area? And Dr. Shrivastava, उनका डिस्प्ले करिए, वो डिस्प्ले को कुछ
doesn't matter. So, DMDNB boys, you may come in front. I have formatted it a little different because
yeah, I'll invite Dr. Anand Mishra to please come here and join.
so I'm just going to highlight not how to evaluate, but what are the things which you should see as complications of PHV as detected by 2D echo. Now, you can switch. That's fine. I'm okay. So I'm going to start on case, and I just want inputs from the DNB students. Anybody can volunteer. And please don't hesitate to be wrong. If you will keep hesitating, you will never go right. So this is a story of a 22-year-old girl.
एक मिनट भैया एप्पल नहीं है दूसरा एक मिनट रुक जा तू देख ले आया
यार ये वाला लगा हुआ था ना अभी इससे आ रहा था
देखियो लगाइयो है सिपोर देखो वहाँ पे हाँ उठा लिया देखो 2 नंबर छोड़ दिया रेजोल्यूशन की है ये तो डुप्लीकेट पड़ी है
So whoever is next can come down, they can figure out.
सर मेरे लैपटॉप से चला पीपीटी
तुम्हारे से नहीं चलेगा
ये पीपीटी अब बना दे दो मेरे
नहीं चलेगा यार तुम्हारे वाले से
सर देख के तो देखो सर
हाँ पिछली बार तो अभी तो करके गया था
सर छोड़ देता है सर बिजी है उसमें है ही नहीं
एक सेकंड होल्ड
एक ही लगाया लॉकडाउन कर देता हूँ इसका रेजोल्यूशन एक मिनट सर टाइम देना सर एक मिनट
अभी तो आया था यार
छोड़ देता है सर
छोड़ देता है
छोड़ता है सर लैपटॉप ही छोटा है अप एंड डाउन कर रहा है एक मिनट जा तो देना 8 नंबर पे डाउन करना इसका रेजोल्यूशन देखते हैं आ गया 8 नंबर। रुक जाइए 1 मिनट, देना स्क्रीन पे।
I think let's not waste time. Whoever is next can come. Achha. Okay. Okay, lovely. So one of the DNB students. This is a story of a 22 years old girl who underwent a triple valve replacement, aortic valve with St. Jude's, 17 millimeters, mitral replacement with 27 Medtronic, tricuspid with 27 ATS. 11 months later, she came with palpitation and dyspnea for 15 days. Are you happy with this combination? And if not, then what would you have done differently? Or what would you have suggested to the surgeon differently? Yes, sir. But I know that the chairperson is Dr. Mahant. Speak up, Sachin. No, they are appearing for DM exam, sir. They'll be asked. So one is that the aortic valve is small. 17 is very small size. Number two is she has got all metallic. She is 22 years. She has to get married. She has to have kids. My choice would have been something different. If at all three valves had to be changed, I would have preferred a tissue valve. With surgeons like Mansab, he would have probably done a root enlargement surgery and put in a larger valve. If not anything lesser than 21 is always pushing you into gradients. Even if it was a metallic valve, two metallic valves on the left side, my choice on the tricuspid would have been a tissue valve, because right-sided metallic valves almost always give a problem. So now we go, and this is her investigations. Her PT-INR was 0.9. ECG was nothing contributory except that there was an atrial fibrillation, and this is what her echo is. This showed a normally functioning bileaflet at mitral. If you look at that side, you'll see that the mitral is opening well. If you look at the gradients across mitral, it is 4. If you look at the gradients across aortic, mean is about 12. Happy? Okay. If you're happy, I'm happy. Now, this is the problem. In tricuspid, if you look at it, you see only one valve, and that also one leaflet, and that also very sluggishly moving. Can you see that? Here. This one. I need a pointer. यहीं पे नहीं, कोई जेब में डाल के ले गया. कौन ले जाएगा? वो तो जेब चेक करने के बाद पता पड़ेगा. Okay. So this is the leaflet. If you look at this, this is moving very sluggishly. Okay. Gradients are high. There is a turbulence across pulmonary tricuspid valve, and the mean PG across tricuspid valve is 11. Happy or not? So, by the way, what should be a gradient, catheter gradient across tricuspid valve? Normal catheter, 0. Good. None. None. So, this is a valve which is kind of stuck. And these are the features. So this is regurgitant lesions. And let me just tell you, I think I have got mixed up somewhere. Instead of stenosis, I have kept regurgitation. But just to complete the story, this is mitral inflow peak velocities. If it is more than 2.5 and PHT is less than 150, it is a sign of regurgitation. Similarly, across severe regurgitation across aortic valve, PHT should be less than 250. Restrictive mitral inflow pattern in acute AR, holodiastolic reversal, and regurgitant fraction more than 55%. And these are the ones for mitral regurgitation. Again, the signal density, regurgitation fraction more than 55%. Effective regurgitant orifice area more than 0.35, and systolic flow reversal in pulmonary veins. Now, this is for stenosis. So one thing is which you can't trust in this kid because she has got too many valves, but loss of prosthetic valve click signal is a sensitive marker for prosthetic dysfunction. And then you have to have velocities across PHV which are increased. Most of the PHVs are inherently stenotic. So all artificial valves are stenotic valves and all artificial valves are regurgitantly valves. Velocity is always higher, and baseline study is very important for comparison. Spectral Doppler pattern is triangular with early peaking. If it is delayed, you are in bad shape. Uh, as a result, mean PG is much less than the max PG, becomes more rounded with stenosis. Velocity is dependent on volume flow rate, hence it is increased with regurgitation and higher cardiac output states. So TE was done. So if you look at the TEE, this is a beautifully functional St. Jude's, little bit of whiff of mitral regurgitation. We'll accept that very gracefully. And this is here, this leaflet is stuck. Never be very confident about tricuspid valve and pulmonary valves in TEE, even though you are fairly reasonably confident that this is the stuck valve, this is a sluggishly moving valve, and there is a regurgitation, which is a big time regurgitation for an artificial valve. You gradients are high, leakages is there, tricuspid regurgitation is there. So always go for fluoroscopy. Now, if you have to be very careful and you have to be, somebody can identify the valves. 3 valves are seen. Functional, non-functional, which is the one which is which one? This one. So this is tricuspid. Then this is mitral. This is aortic. So this is a fluoroscopy across. Now the patient was thrombolized with streptokinase. Again, my choice would not have been streptokinase, though there are enough and more data for streptokinase, but my choice would have been something different. But post thrombolysis, this is the, so you know the difference between the earlier and the post thrombolysis. This is what it is. So this is leaflets moving normally and reduced from 11 millimeters to 1 millimeters of mercury. And I'm not going into the details of what does the data say. But the sum and substance is, say if it was a left-sided valve which was stuck, what would have been your choice? Given a choice, you have a stuck valve. What do the guidelines say? Left-sided surgery, there is some data to suggest that if the thrombus burden is small, you can still manage to thrombolize them. But by and large, as a matter of rule, right-sided respond better, and treatment of choice is thrombolysis. Left-sided, if they are stuck, then prefer a redo surgery. Okay. Now, we will go for another case. 55 years old lady, CMV in 1997, MVR in 2008, left hemiparesis with seizure disorders with lesion in right MCA territory in 2012, intracranial hemorrhage in 2013. Presents with complaints of shortness of breath for 1 week. ECG reveals atrial fibrillation and heart rate of 150. This is the mean PG across prosthetic mitral valve. Happy, unhappy. So mean PG is 7, mean PG is 6, 2 times taken. Atrial fibrillation, you could have taken it as many number of times, but trust me, it is not more than 8 or 9. Happy? So you let the patient go home. This is the echo. Now you remember the earlier picture where the mitral was there? Is this normally functioning metallic valve? One is stuck. One is stuck. Good. With a mean PG of 6. You have to, one is stuck with mean PG of 6. Okay. Let's see what the TR jet velocities are. TR jet velocities are high, PA pressures are high. IVC dilated. Very good. Now this is the problem. When you want to click it with laser pointer, it doesn't click. Anyway, there are hardly any. So this is stuck. Somebody will have to give me an explanation. Why are the PGs so low? So this is stuck with some thrombus or whatever. There is a layered thrombus here. Can you see that? So this is a stuck valve. And this is the 3D. 3D is very useful in mitral. And if you look at this, this is a 3D with stuck valve. 3D with stuck valve. Fluoroscopy, one leaflet moves beautifully, another is stuck. We always do a fluoroscopy. We don't rely on echo alone for decision making. Now, if you look at this, this is only one leaflet moving with mean PG of 7. And this is both leaflet moving. This is somebody else's. But for sake of comparison and for sake of teaching, I have put both simultaneously so that you know that how the two leaflets move here normally and how one leaflet is moving. Now you'll have to tell me why is the gradient slow. It is very evident here. Very good. So it is LVDP which is high. When the left ventricular end diastolic pressure is high, this is a poor LV. If the left ventricular end diastolic pressure is high, you'll get low gradients. This is what we were discussing about 4 minutes back. See that? Okay, lovely. So again, these are the features. There is velocity ratio which is useful, and this LVOT VTI versus aortic valve VTI is for aortic valve. You can take help of that. If it is less than 0.7, 0.25 is the real cutoff, but if it is lesser than that, so your antenna should go up. And the advantages of velocity ratio is takes volume flow rate account into. It does not require outflow tract diameter measurements. It is easily measured and reproducible, and it is less dependent on valve size. So this is a silent Doppler prosthetic valve thrombosis. It is very well documented. Okay, one more, and then I'll show you a few things which probably you will not be able to see ever, because again, this is stuck mitral leaflet. Same thing, high gradients, classical. Here there is mean PG of 26, and then there is a difference between pannus and thrombus. If it is coming from outside to inside, then it is a pannus. If it is from inside to outside, it is thrombus. And also what you can do is you can see the echo density. If the echo density is more like a swing link, it is probably pannus. If it is softer like a thrombus, which all of us are more used to seeing, then it is a thrombus. So these are the differences. Thrombus may occur anytime. Pannus is usually at least after a year. Obstruction is related to thrombus, typically more acute. It is developing slowly. It is reasonably, actually this is not correct. Here I have written that there is thrombus is associated with inadequate anticoagulation, which is correct, but PANAS has poor relationship, anticoagulation is not correct, because PANAS also has some correlation with bad anticoagulation. And when you do a histopathology of PANAS, you'll find that there is layering of tissue in between thrombus. So it is probably not associated, or it may be associated, but this is what the histopathology would show. Larger, softer, and more mobile, small masses, more echogenic, and mostly involve suture line. Best distinguishing feature between the two is video intensity ratio, which I was talking about. And if this is less than 0.4, then it is thrombus. If it is a mass or a prosthetic, which is equal to prosthetic valve swing ring, if it is as close as 0.7 or something, then it is there. So these are prosthesis versus PANAS formation. And then there are strands, endocarditis, there's several things which you can see. And this is an example. Now this won't move. This is root abscess. Let me just go into the original pictures if I can, and then I'll show you some. I just want to show you this is a normally functioning valve, but you'll not be able to see it. The younger crowd will not be able to see. This is a typical ball and cage, which the surgeons have stopped putting. This is the cage, and this is a ball which is going bobbing up and down. This is normal, but I just wanted to show, because keep it at the back of your mind. Some odd patient 20 years back must have had it, and then you will figure out what it is. So this is a typical dehiscence. See this? This valve tilts up and down. And when you put a color across, I'll show you again. This is dehiscence here. And when you put some color across this, you'll find that this is a severe aortic valvular regurgitation, which is occurring from the same area. And these can be sorted out if it is not too big. These can be sorted out by just plugging it. You can, paravalvular leaks can be these days managed trans catheter. Okay. One more example of this is mitral, and here there is, you can see is, why is this not a thrombus? Why is this in vegetation? One is, of course, history of fever and everything. Why is this not a thrombus? So one is that it is flagellar, it is out of phase motion. And second is, in low pressure chambers like atria, if it is a thrombus, most of the times, 96% of the times, it should be associated with spontaneous echo contrast. Unless if it is something which has moved, say in RA, if it has moved from IVC, then you won't see spontaneous echo contrast. But absence of spontaneous echo contrast with a mass in atria, don't have thrombus as your first line thought process. It could be endocarditis, it could be full-term normal pregnancy, but it cannot be thrombosis. So I'll try to finish here and see if there is anything else. Root abscess I have to show you. Okay, let me just hunt for it if I can. Aortic root abscess. Sorry, next time maybe. But this is aortic root abscess, I'm not able to see. Thank you very much for your patient listening. Any questions if you have, I'll be very happy to answer.
Thank you, sir, for the presentation. Would you like to comment on transcatheter aortic valve implantation echoes like the
TAVI?
Yeah.
I think somebody else is talking on it, but if you want, I can show you TAVI. You want to
My
see?
question is that the self-expandable valves have better hemodynamic parameters on echo, but those better hemodynamic echo parameters are not correlated to clinical improvement over long-term follow-up. So what is the role of ET by AT ratio on echo as far as prosthetic valve dysfunction is concerned?
So whether it is self-expanding or balloon expandable, I am not too sure whether there is any significant hemodynamic difference. If there is a difference, yes, there is a difference in the need for a pacemaker, and horizontality of the aorta defines which is the one which is better. The balloon expandable are better if it is more of a horizontal aorta rather than a vertical aorta. As far as hemodynamics is concerned, AT by ET ratio holds true for regardless of which valve you are using.
Thank you for the comment. The house is open for comments. Any questions or comments?
Sir, I have one question. What is your protocol for choosing prosthetic valve and tricuspid valve in the young patient? You have chosen for a mechanical valve. Is it the protocol to choose mechanical valve? In
No,
tricuspid?
I was very critical of that. I was very critical of that because tricuspid valves, they don't misbehave too bad, even for adults or younger people. And prosthetic valve choice for tricuspid should be a tissue valve. It's a low pressure circuit. The gradients are so less, wear and tear is much lesser. Why unnecessarily give it?
There, people may think that we are already giving anticoagulant. No, why not to take tricuspid valve and mechanical? This is a wrong concept. This is what I want to communicate.
So that's exactly what I said, that if three valves are put, even if the left-sided valves had two mechanical valves or metallic valves, the right-sided should have been a tissue valve. But to defend the surgeon, I would still say that there is enough and more data which says that tissue valves versus metallic valve, tricuspid can be as good or as bad.
Yeah,
There is
especially
data.
in endocarditis. Especially in endocarditis.
Other in the lighter vein, I would like to say it is a cardiologist friendly to put a mechanical valve on the tricuspid valve because you can thrombolize and you can do something.
And,
Lighter vein.
and thrombolize again and again.
Yeah.
No, I think to be my junior colleagues, it's like putting three valves, replacing three valves in a patient. Some of our masters of cardiac surgeons, they have written in one of the book, this is changing one disease into the another disease.
Yes.
It's definitely a disease of the valve. It will be there. Sooner or later, this patient will come to you with valve problem.
Correct.
But I have a one point, especially to make those who are doing echos after valve replacement, right? When you are referred, you get a patient who had a valve replacement done. I think it will be good idea to know which type of valve has been done.
You
right?
must have
That is
baseline data.
fundamental thing. Size of the valve, type of the valve, before you make a report on this. Because why I'm saying this, especially the small size valve, in aortic position, you have to put a 19 millimeter or a smaller annulus. This valve resting gradient will be higher. See, this will be right from the time of operation. So whenever these valves, now these companies, they write what will be the resting gradient in a particular valves, especially Onyx valve, which is the latest valve. This have a 19 millimeter will have a resting gradient much less than a St. Jude valve. So same way, every patient are given nowadays with this, the type of the valve, resting gradient, smaller the valve, more the gradient. So when we express, we face this problem, asymptomatic patient, but going for a routine echo, the gradient is sometimes comes written as a 50 millimeter of mercury, which could occur in some of these 19 millimeter or 17 millimeter valve put in aortic position. I think that should be, you should be aware. I've seen some of the patients, they have gone to doctors, they have done a routine echo and put a diagnosis of it severe stenosis, moderate stenosis, patient asymptomatic. So this patient prosthetic mismatch is a phenomenon which I think as a echocardiographer we should be aware and mention. And this is only possible when we know which type of valve, how small this valve is, before we label that this patient is suffering from a valvular stenosis, right?
So I think great, wonderful.